can you please state your rank, name, and what you do?
You're right. I'm Captain Wayne Mars Jr. I'm a licensed clinical social worker, and I'm the State Behavioral Health Coordinator working for the Office of the State Army Surgeon.
Okay. And what is your prior experience, and what do you currently do for the Texas Army National Guard? I guess elaborating a little bit on what you said.
I've been a social worker since obtaining my bachelor's degree in 1988. I've obtained my master's degree in social work in 2001 and my clinical license in November 2007. I've been in the field of social work the whole time. Upon obtaining my clinical license, I immediately started working for the Army as a behavioral health provider on the civilian side at Fort Hood. I've worked with the Army Family Advocacy Program and at the Fort Hood Emergency Room. Throughout my career, I've worked with soldiers in the military. I've worked with the elderly, with the disabled. I've investigated child abuse, worked with acute mental illness, with chronic mental illness, with poverty. As the Texas Army, and I've been a behavioral health officer with the Army National Guard for almost 4 years. In my current role, my job is to ensure that the 19,000 soldiers in the Army National Guard are safe, that we provide intervention services to keep them safe and to keep the Army effective. I supervise 5 social workers across the state whose job is to manage soldiers with high to moderate to high risk behavioral health issues, and work on helping them become fit for duty or helping them obtain a medical discharge. And if they won't take action, then we help the command get them moving towards a disposition. We don't let them do nothing and hope to get better.
Okay. And based upon your duties and responsibilities as an MS officer, a social worker, how do you reach out to the varying commands and convey messages relating to the importance of behavioral and mental health and welfare?
A lot of what we do is education. Another part of what we do is, since we manage moderate to high risk soldiers, we routinely see serious incident reports and we contact the command regarding the serious incident report. We also look at soldiers with existing or expiring behavioral health profiles, and we work on getting them assessed by a behavioral health officer. Reaching out to command is largely one by one on a situation by situation basis, and building those relationships so that when they have a challenge, that they know who to call and they can get a straight answer. And so it's a lot of the informal relationships. It's also building relationships with community partners such as the state family counselors, the medical command, behavioral health providers, the medical command case managers, community resources, the medical readiness NCOs, and we work collaboratively to try to identify how we can all assist each other and take a team approach to addressing soldiers with mental health illness. The colonel who invited me out to the field, he made the comment that the Army's a contact sport. Nobody gets through unscathed. I think the Army's a contact sport, and all of us have bumps in the road. Most of us have survived all kinds of relationship problems, the deaths in the family. We've all had stuff that have been difficulties in our life. We want to try to make sure that it's normal to have stuff, but it's easier if we intervene early versus wait till a crisis develops.
So you talked a little bit about how you provide care for soldiers. What are the common difficulties that you may see in providing care, and what barriers do you commonly see?
Okay. One of the bigger challenges is geographic in the state of Texas. We have 19,000 soldiers throughout the state of Texas, and yet all of the behavioral health officers, none of them are west of the I-35 corridor or east of the I-45 corridor. So we have parts of Texas such as Weslaco, Brownsville, Laredo, Abilene, Brownsville, Midland, Lubbock, Amarillo, and El Paso that have behavioral health needs. So geographically, responding to those needs across the state becomes somewhat of a challenge in identifying the resources in these regions. And then how do we utilize the current behavioral health services to reach those areas? Another challenge is the stigma associated with behavioral health. Most soldiers don't want to, and rightfully so, want to come see a behavioral health officer in their office. We find it's a lot less stigmatizing if the behavioral health team are out in the field. It's easier to talk to a soldier behind a Humvee or on a ruck march or out doing weapons training than it is to have them come into an office.